Hello and welcome to Chapter 24, Hematologic and Renal Emergencies. So we're going to look at the hematologic system and the renal system. So the hematologic system basically is blood, okay? Represents its own organ system, has specific functions, control of bleeding by clotting, delivery of oxygen to cells, removal of carbon dioxide from the cells, and removal and delivery of other waste products to organs that filtrate them and remove it. So the blood is made up of solid components. It's got the red blood cells, the white blood cells, the platelets. They're all suspended in plasma. And medications can affect some of these components of the blood. Okay, blood clotting. So aggregation of platelets is the body's most rapid and initial response to stop bleeding. Clotting factors are a group of proteins produced in the liver and released into the bloodstream. And once activated, these clotting factors form clots through clotting cascades. So they go to the place and they just kind of cascade down. Coagulopathies. This is abnormal clotting of the blood. It can occur when the body forms clots too readily or the patient clots too slowly. Certain diseases make patients prone to poor clotting, such as advanced liver disease, hemophilia, von Willebrand disease. All of these things kind of create this poor blood clotting. So how do we identify these patients? Certain medical conditions, medications in which the normal ability to form clots can worsen a patient's disease. Patients with prescribed blood thinners. Okay, these are patients that are more prone to having life-threatening bleeding when injured than patients not on these medications. And you'll see that like some of these patients are the older type patients who've had a stroke or they've had a heart attack before. They will be on blood thinners, and so what happens when they fall, because geriatric patients fall a lot more, they will get a lot of bruising and they'll bruise a whole lot easier, and sometimes if they bleed, then it's hard to stop that bleeding as well. So anemia is the lack of normal amount of red blood cells. Acute anemia is a sudden blood loss. Chronic anemia can be caused by excessive menstrual periods, slow GI bleeding, or diseases that affect the bone marrow. Sickle cell anemia. This is a genetic disease affecting the red blood cells. It's more prevalent in certain ethnicities, such as African Americans or Indian or Middle Eastern descent. So basically what happens is the red blood cells have a defective shape, and it resembles a sickle. If you don't know what a sickle is, think the Grim Reaper. So that staff-looking, menacing thing that he carries is a sickle. These cells have a short lifespan, leading to anemia. Complications of sickle cell anemia. There's destruction of the spleen. There's sickle pain crisis, acute chest syndrome, priapism, stroke, and jaundice. Typically, when we see these patients, they're in that sickle cell crisis, and pretty much all we're going to do is just pain management for them. So 1 in 12 African Americans has the sickle cell trait, and it doesn't always lead to complications, and it's possible to lead a normal life with that sickle cell trait. So we're going to, for these patients, we're going to administer supplemental oxygen, monitor for inadequate respiration, monitor for signs of hypoperfusion, and transport to a stroke center if a stroke is suspected. Alright, so let's watch this video.
Sickle cell anemia is a genetically transmitted disorder marked by a severe reduction in circulating red blood cells. Red blood cells are produced in the red marrow of bones such as the vertebrae, ribs, and body of the sternum. Red blood cells are filled with hemoglobin that enables them to carry oxygen from the lungs to all of the body tissues. In sickle cell anemia, red blood cells contain an abnormal form of hemoglobin. As the red blood cell deoxygenates, the hemoglobin forms crosslinks with other hemoglobin molecules and long crystals develop. Crystals continue to form as oxygen is released and the red cells assume a sickle shape. Sickled red blood cells are inflexible and rigid and cause mechanical obstruction of small arterioles and capillaries, leading to pain and ischemia. Sickled cells are also more fragile than normal, leading to hemolysis. Tissue death secondary to ischemia progresses to organ failure with repeated occlusive episodes. Sickle cell anemia cannot be cured. Treatment is aimed at preventing sickle cell crisis, controlling the anemia, and relieving pain. Blood transfusions and fluid replacement expand blood volume and oxygen exchange needed for reperfusion of occluded vessels.
Okay, so I kind of hope that explains a little bit better on the sickle cell anemia. Alright, so let's talk about the renal system. So there's components of the renal system which include 2 kidneys, 2 ureters, and 1 urethra. It's responsible for filtering blood and removing waste. It maintains fluid balance, and it maintains the acid-base balance as well. So there's many diseases that affect different portions of the renal system, and they range from minor to life-threatening. Urinary tract infections. So these are the most common that affects the renal and urinary system. I'm sure most of us have had a UTI at one point or another. It's caused by bacteria. It's usually limited to the bladder. It can cause pain and frequent urination. And if left untreated, it can result in pyelonephritis, as the UTI ascends up in the ureter into the kidney. UTIs also have that specific smell, like I was talking about, like with the GI bleeds. So these patients have a it's not, it almost smells like an ammonia, but it's not quite. But there is a definite smell, and when you walk into like a nursing home, you'll be able to tell, because those patients frequently get UTIs. Along with UTIs, let's back up. So along with UTIs, when you have a geriatric patient that gets a UTI, if it progresses and does not get taken care of, they can become altered. And at that point, you're really looking at maybe the patient having sepsis, and we need to treat aggressively with those patients. All right, so kidney stones we talked about a little bit in the last lecture. They're usually made up of calcium and formed within the kidney. When in the kidney they cause no symptoms, they become dislodged, can cause unilateral flank pain that radiates to the groin area, and patients may report nausea and vomiting. So patients with a urinary catheter, so as a result of renal obstruction of bladder outflow, or neurological disorder, the use of urinary catheters is to drain urine. It's commonly inserted into the urethra, and may be placed through the skin, and complications of UTI and local trauma site at the catheter insertion site. Renal failure. So this occurs when kidneys lose the ability to adequately filter and remove toxins. Acute failure typically results from shock or toxic ingestion. Chronic failure may be inherited or secondary to damage from uncontrolled diabetes or hypertension. So end-stage renal disease is an irreversible renal failure, requires dialysis, so either hemodialysis or peritoneal dialysis. 90% of patients receive hemodialysis in specialized centers. There's more than 400,000 Americans on dialysis who are treated in dialysis centers, and they undergo 3 treatments a week, each lasting 3 to 4 hours. Only 8% of them treat themselves at home. And these end-stage renal patients often rely on EMS for transport to and from dialysis, and they do. Okay. The patient is, so let's talk about hemodialysis now. So patient is connected to a dialysis machine that pumps the blood through specialized membranes. Treatments last several hours, multiple times a week. Okay, so the patient has a port, a shunt right here. So what happens is the nurse or dialysis tech that is starting their dialysis treatments is going to access this shunt. Blood pressures, you can't do a blood pressure on the side that the shunt is on as well. So yeah. So what happens is we remove the blood for cleansing. We monitor that blood that comes out. It goes through a pump. And then there's a heparin drip type pump that goes into the blood at some point, and it prevents it from clotting inside the machine. And then we monitor it again. We get the dialyzer, and what that does is it takes all of the toxins, the carbon dioxide, I guess not carbon dioxide, but it takes all the waste products in the blood that can't be excreted through urine because their kidneys are not working to filter all of that. It takes it out and then replaces it. And sometimes it will also take like fluid off as well. These patients sometimes have edema, and so we're taking fluid off as well. Okay. These patients also are very weight controlled. They monitor their weight daily. They also monitor their intake of salt, or they should be at least, and they monitor various other things. So there's 2 types of access to the blood circulation. There's a 2-port catheter and then an AV fistula. It's a characteristic thrill when palpated. So basically what that means is it kind of, it doesn't pump through the blood, it flows through the blood. Okay, so this is a 2-port catheter for hemodialysis. It's inserted into a major vein of the torso. This is a fistula. This is typically what you'll see. You'll be able to see this as well, and yeah. So peritoneal dialysis. Typically, patients who are on peritoneal dialysis can do dialysis at home. It uses the peritoneal's large cavity's large surface area, and a special fluid is infused into the abdominal cavity and left for several hours to absorb waste and excess fluid. That fluid is removed and discarded. So continuous ambulatory peritoneal dialysis is a gravity exchange process repeated several times a day. Um, and a continuous cycler assisted peritoneal dialysis is a machine that's used to fill an empty abdominal cavity while the person sleeps. Okay, so this is that peritoneal dialysis catheter. Um, Goes right into the abdomen. This gets hooked up to fluid, and fluid is exchanged. Okay, so medical emergencies in these patients, there's two broad groups. There's the loss of normal kidney function, and then complication of the dialysis treatments. Most dialysis patients have underlying medical factors such as diabetes or hypertension. And they usually relate to the patient missing dialysis. It is of utmost importance for these patients to receive their dialysis in a timely fashion. Like I said, they go 3 days a week, so you've got patients who go, Monday, Wednesday, Friday, and then you've got patients that go Tuesday, Wednesday, or Tuesday, Thursday, Saturday as well. So it's of utmost importance that these patients get it, because then if they don't, they can start, although that fluid backs up because there's no way for the kidneys to excrete it and filter it, so that the fluid just kind of backs up into the system, and we get shortness of breath, edema, and electrolyte disturbances similar to CHF. So for these patients, our patient care, we're going to assess ABCs, obtain vitals, and be aware of fistulas. Again, you can't do a blood pressure on the arm that the fistula is in, so you have to do it on the other side. Administer oxygen to these patients if they need it. Monitor their vitals closely and have an AED available if you need it. Transport to a facility capable of dialysis. So complications of dialysis: bleeding from the AV fistula site, clotting and loss of function of the AV fistula, bacterial infection of blood due to contamination at the AV fistula or dialysis catheter site. In stage with complications of dialysis, we're going to assess their ABCs, control bleeding, use direct pressure, elevation, and hemostatic dressings as needed. If the bleeding cannot be controlled by other means, a tourniquet should be applied. If you are responding to a dialysis clinic for these patients, your best resource is going to be the nurses and staff at the dialysis clinic. They should have already started most of this. If they're going to be putting a tourniquet on, they're obviously going to be calling for an ambulance to transport that patient. Treat for shock, keep the patient supine and warm, and if peritonitis is suspected, transport dialysis fluid for confirmation. So kidney transplant patients, kidneys are the most commonly transplanted organs, approximately 16,000 transplants per year. Patients spend their lives on a special class of drugs that help prevent organ rejection and increase their susceptibility to infections.
There are two types of renal or kidney failure: acute and chronic.
Acute renal failure is the sudden loss of kidney function that develops as a result of an injury or damage to the body in general, or the kidneys in particular.
Acute renal failure is caused by a blockage of urine flow out of the kidneys and into the bladder, exposure to certain drugs and/or toxic substances, or significant loss of blood, or a sudden drop in blood flow to the kidneys. Kidneys that have pre-existing disease or damage are at higher risk for acute renal failure.
Signs and symptoms include confusion, drowsiness, decreased urine output, small breathing, dyspnea, tachypnea, and coma. Acute renal failure is a very serious condition with a mortality rate in excess of 50%. Chronic renal failure develops over a much longer period of time as nephrons lose their ability to function and are replaced by scar tissue. Usually, this takes place over the course of many years.
In the early stages, there may be no symptoms, and progression may be so gradual that symptoms do not occur until kidney function is less than 1/10 of normal. Diabetes and hypertension are the two most common causes and account for approximately 2/3 of the cases of chronic renal failure. The goal of treatment for all renal failure is to identify and treat any reversible causes, as well as preventing excess accumulation of fluids and wastes, while allowing the kidneys to heal and gradually resume their normal function. In some cases, dialysis may be necessary. Dialysis is a method of removing toxic substances from the blood when the kidneys are unable to do so. Some patients may require a renal transplant to implant a healthy kidney into a patient with kidney disease or kidney failure.
Alright, so chapter review. So the blood delivers oxygen to the cells and it removes carbon dioxide from the cells and controls bleeding by clotting. The blood consists of red cells, white cells, and plasma. Anemia is that lack of red blood cells in the circulation. Sickle cell anemia is an inherited disease in which a defect in the hemoglobin results in that sickle shape to the red blood cell. That misshaping inhibits movement of red blood cells through capillaries, causing a sludging effect and blockages in smaller blood vessels. The renal system is comprised of the kidneys, the ureters, the bladder, and the urethra. The kidneys perform vital filtering of the blood to remove waste products. They also help maintain water balance within the body. Problems with the renal system include infection, kidney stones, and renal failure. Renal failure is a condition in which the kidneys are unable to filter that waste and provide a balance of fluids and electrolytes in the body. Dialysis removes excess fluid and electrolytes from the body by filtration. Dialysis may be performed in either in one of two ways: hemodialysis or peritoneal dialysis. Hemodialysis at a dialysis center is generally performed 3 times per week. Peritoneal dialysis is done at home and is usually done several times daily. So major complications in these patients with end-stage renal disease can occur after the patient has missed an appointment from infections or as a result of bleeding from hemodialysis access sites. So things to remember: blood has a specific cellular component. Abnormal blood cells can significantly affect patients. The renal system is critical to maintaining homeostasis, and renal failure can be chronic or acute. End-stage renal disease is managed through dialysis. So, questions to consider. Does my patient have a history of sickle cell disease or end-stage renal disease? Does my patient have an AV fistula? Okay. And will I need to make an early request for ALS because of complications from a missed dialysis appointment? Remember, those patients have CHF-like complications, symptoms, because all of that fluid is coming back up into them. So, all right. So you have a patient who is transported routinely for dialysis 3 times a week. She was sick and canceled the trip yesterday. Now she calls saying she can't breathe and feels like she is going to die. Is it possible that she has a legitimate complaint after missing dialysis by only 1 day? Absolutely. These patients, if they're on dialysis, they need that every single day. it's very critical. It's a very legitimate complaint. Again, these patients can develop CHF like symptoms because the kidneys are not filtering out that water. They're not removing the waste. They're not removing that water that needs to be removed from the body to maintain the balances. So you remember, let's go back to like the cells chapter. Okay, so you go back to the cell. The cell has fluid that is inside the cell. There's fluid in the interstitial space outside of the cell, and then there's fluid inside the vessel, the veins, the arteries, and all that. So what happens when the cell says, "Hey, I need more fluid"? It brings in fluid from the interstitial space. The interstitial space says, "Hey, you just took some fluid away from me. I need to get that." So it takes it from the vessel. Okay, the vessel says, "Hey, I need more fluid," so it makes us thirsty. So if there's a problem in there, where the problem becomes is the cell either is taking on more fluid, and that interstitial space is the cell is saying, "Hey, I need more fluid, but I can't get it." Or I need more fluid. I need more fluid, and the interstitial space is saying, "Hey, you've got plenty of fluid, but I can't give you any more, so I'm just going to hold on to it until you need it." And so it just holds it in those places for the like the edema and all that stuff. So it says, "Hey, I've got all this fluid in here. I can't do anything with it." So it goes to it tells the kidneys, says, "Hey, kidneys, I need you to do something with this fluid. I've got too much in my space." But the kidneys can't do anything with it because the kidneys are not functioning properly. I hope that makes sense. I know I went off on a little bit of a weird direction, but I hope it makes sense. So if you have any questions, you can call me, text me, email me. Let me know your questions, and I will answer those questions as soon as possible. And I will see you in the next lecture.